Provider of contact hours is the California Board of Nursing. The Philippine Nurses Association of America Foundation is an approved provider of continuing nursing education, but by the California Board of Registered Nursing, CEP 14134. The speakers have disclosed no conflict of interest. The purpose of this series is to discuss issues that relate to COVID-19. PNAA and the speakers are not able to comment on an individual's risk factors or medical issues. For medical and personal concerns, please contact your healthcare provider. For current updates, please check coronavirus.gov or your public health department. Zoom instructions for everyone. All participants will be muted for the entire session. Only the speakers, the education chair, and the chat monitors will have open microphones. All questions must be typed in the chat box at the bottom of your screen. It is best to use speaker's view located on the top right of your screen. It's a little square with 3 dots on top for a viewing of the speaker and the slides. The gallery view will show all the participants. Thank you. We shall begin. I'd like to introduce our speakers for the night. Carol, I'm disabled again. Carol?
Got it, May.
All right. Our speakers for the night are two dynamic nurse leaders that we know very well. Their topic is caring for the caregivers during the COVID-19 pandemic. The first one is MaryAnn Donohue-Ryan, Ph.D. RN, APN, NEA-BC, CPHQ. Dr. Donohue-Ryan is a former chief officer at several New York, New Jersey organizations with clinical expertise in adult psychiatric mental health, advanced practice nursing in inpatient ambulatory settings. Dr. Donohue-Ryan's doctoral dissertation was the first in the nation to study stigma associated with HIV, and with Dr. Maureen Schneider recently contributed an article to myAmericanNurse.com, which is in press. And the title of that article is Caring for Ourselves and Each Other During the Coronavirus Outbreak. Currently, Dr. Donohue-Ryan serves on the editorial board of Nursing Economics and the advisory board of Felician University. He's a past president of New Jersey State Nurses Association. He's an American Nurse Association enterprise consultant and is currently based at Chilton Medical Center, Atlantic Health System, Pompton Plains, New Jersey. And we had her as one of our speakers in Boracay. The speaker number 2, and they'll be joining the podium in and out, both of them, is Dr. Schneider, Maureen Schneider, PhD, MBA, RN, NEA-BC, CPHQ, FACHE. Dr. Schneider is Chief Nurse and Operations Officer at Chilton Medical Center, Atlantic Health System, Pompton Lakes, New Jersey. She has held several senior leadership positions in both academic and community medical centers in New York and New Jersey. She presently serves as chairperson of the Board of Trustees for SpringPoint Life, serves as several boards in education, nursing, and healthcare. She is also the past president of the Executive of New Jersey. Dr. Schneider lectures and has published several articles, and also an adjunct professor at Seton Hall University, focusing on business at the graduate and doctoral level. These dynamic nursing leaders are honorary members of PNAA New Jersey and have been supporting us through the years. Thank you both to Drs. Donohue-Ryan and Schneider. Thank you so much, and now they shall begin their talk. Let's give them a warm applause.
Thank you very much.
Thank you as well. And I want to shout out to Susan and Marley. Love you both. Hope you're on the line. I see Susan. So Marley, I hope you're there too. Miss you both.
I miss you too. Missing you a lot.
So do you want me to get started, MaryAnn, or do
Sure,
you?
go right ahead, Maureen.
All right, so welcome, and we're very happy to be here tonight speaking with you. And PNAA is always so warm in my heart because my staff from Community Medical Center really indoctrinated me very early on to the PNAA, and I love them all down there, and they're everywhere now too. So this is my privilege actually to spend time in speaking with you tonight regarding this pandemic that we were dealing with and still are dealing with. My segment really has to do with Chilton Medical Center, so I wanted to give you a little bit of an overview of it. It's a smaller hospital. It's about 260 licensed beds. We have about 9,000 admissions, 619 births, and 1,500 or so inpatient surgeries, 45,000 emergency visits, and over 156,000 outpatient visits. We have about 713 physicians and probably around 1,450 employees. So when this particular situation occurred was on March 9th, actually. Next slide, please. Next slide. All right. We're giving a depiction. I'm sorry, go back one. Just one.
There we go.
That's great. Okay. So, no, okay. Go forward one. There you go. This is just a fluid picture of what Chilton was experiencing. We had just had our magnet surveyors walk through the door on March 9th in order to survey our hospital. And as we were visiting with them and ensuring hopefully a successful survey visit, our first COVID patient came through the door in the emergency department. That changed our world actually over the next several weeks because we began to get increased visits from the emergency department to the point that we needed to, as you can see on March 15th on this timeline, we started to realize that we had to do some major conversions of our intensive care unit. We started to slowly subdivide the ICUs in order to be able to incorporate both COVID as well as non-COVID patients. We started off with a barrier door that helped us to just move the barrier as we started to see that we needed to now make more room for COVID patients. Ultimately, the barrier came down and all 12 beds were managed very quickly to fill up. And then we had an adjacent, another 9 beds of intermediate, which also then wound up becoming an ICU, which of course was not in our license. So now we had 21 beds and we were licensed for 12. And then as the weeks went on, we started to see we needed more ICU beds. And we took over a intermediate care unit, and actually that was about 32 beds. And we actually made probably about 12 beds of those to be ICU. So all in all, we wound up with over 31 COVID patients. And then we also, obviously, as other hospitals have done too, is stop our elective surgeries. We still did emergent surgeries, but we took our PACU, which really wasn't functioning now because of the elective surgeries being deferred. We wound up using that as a non-COVID ICU of another 10 beds. So all in all, we had over 41 patients in ICU. So as the timeline continues on, you can see that we have been advancing, and as of April 30th, we wound up starting to think about closing that PACU and starting to reassemble patients back to, on the reverse pattern, back into our intermediate units and slowly start to create COVID and non-COVID ICUs, less and less of COVID. And by today's standards, actually, we've got probably about 6 ICU patients still that are COVID positive. And then we've moved other ICU patients into the other side of our ICU. We still have about 8 of those. So we have about 14 patients in total for the ICU. So this was a maddening situation because we had to make these changes quite quickly. The staff really was very resilient. And it really took the organization by storm. So the next slide, please. You can see the first attributed experience was in Wuhan in December of 2009. We also saw that Hubei province also in November had this experience. And then first publicly reported death in the United States was actually attributed in Washington State in February of 2020. And then it moved on to California, and then Hartford into New York, and then into New Jersey. For Chilton Medical Center, I could say that because we were close to the New York border, we wound up getting patients, probably one of the first groups of patients in New Jersey from the New York market. And then we quickly saw our other sister hospitals around us start to take on patients as well. Next slide, I'm going to turn it over to MaryAnn.
Thank you. Thank you very much to PNAA and PNA New Jersey, and of course, Maureen Schneider, dear colleague and friend. We're lucky to be able to be presenting tonight. In terms of the epidemiological perspective, that was so well discussed last week with Dr. Francisco C. As I said earlier, before this program started, I had the chance to listen to him twice today. Once to hear it the first time, and the second time to really take some serious notes because he's so well versed in it. It is on YouTube for future reference. So meantime, everything we knew or thought we knew about COVID-19 is surely changing at a rapid pace. So when Maureen was just saying that the first publicly reported death we thought was first attributed to Washington State, and then turned out to have originated actually almost a month before that in California. So we really don't know the exact date when the COVID experience really hit our shores. So as you can see from the slide, the European experience was somewhat different, and they all seem to have converged. On January 24th, that's when the first 2 European cases were confirmed in France. By February 1st, 8 European nations had confirmed cases of COVID-19. And a month later, that count had risen to 24 countries with at least 2,200 cases, most of them occurring in Italy, who suffered greatly during the pandemic. And on March 11th, Italy eclipsed 10,000 cases, and that's when the World Health Organization declared the outbreak a pandemic, the first pandemic that it declared since the H1N1 pandemic in 2009. And that's actually also when China, the original epicenter, first began to see drops in their daily counts of new cases. So March, unfortunately, saw such an exponential spread of the virus, as Maureen said, throughout the United States, with all 50 states reporting cases by March 17th. So if you can think back to Maureen's slide where she had the timeline there, and how, yes, we welcomed our magnet surveyors on March 9th, and that's when the first COVID patient also arrived in the emergency room. Well, it was on March 23rd when Maureen had the foresight to implement a widespread plan for the organization based on wellness for the staff to be able to manage what she saw as would be quite a devastating event for the organization and for our nation. Next slide, please. So as we say, that air travel was largely responsible for the growth and exponentially for the infectious cases throughout the United States and the world. And in fact, where we're based here in the New York, New Jersey, Connecticut region, many of our initial cases are believed to actually have its origins in flights from Europe that landed at JFK and surrounding airports in New York City, with the virus circulating in the area weeks beforehand. So there was a study conducted by the Icahn School of Medicine at Mount Sinai, and they believe that the virus was perhaps circulating as early as late January in the New York City area. And there was a rush for sickened travelers to return home, especially with our president closing the borders of our country. So that made people come back quicker who were perhaps too sick to fly, but there was no screening at that time. So as Dr. C said, and he was quoting Elvis Presley here, easy come, easy go. The virus is very easy for the spread to occur, especially with asymptomatic individuals. Next slide, please. This is one of, I think, the nation's favorite websites because it is updated every day after 8 p.m. And we can definitely see the top areas that were originally impacted was certainly Queens, New York area, But that area, as you can see from the left there, is now surpassed by Cook County in Illinois. So there are peaks and valleys and peaks and troughs and everything else that in between. You can see from this map, as I said, is updated daily, what the nation looks like right now. Next slide, please. So this is another website that's changed daily, and that is the New York Times website. And recently they posted the states with the rapidly declining cases. And as you can see, we're living in New Jersey that had one of the nation's, right behind New York City, largest number of cases. We were particularly hard hit. Well, we've managed to reduce our case incidence down by 38%. From 25 to 16 cases per 100,000. But look at the next most rapidly declining cases, Missouri, from 4 to 2.6. So we really were hit extremely hard, or have been hit really hard. And then you can see, on the other hand, the states with rapidly rising cases, with South Dakota increasing by 7 to 10 cases per 100,000 patients, and then Arkansas rising by 2 to 3. And then with Texas and Florida having lots of new cases being reported as more and more states clamoring to reopen. So all of this is expected to change as the rise and fall of reported cases has as much to do with the viral spread as it has to do also with the availability of testing. And as we shall see, that was one of the early problems for us. Next slide, please. So with all of the changes that started happening with the reporting of new cases coming in from our first reported case in the United States to our first case at Chilton Medical Center, right away from the beginning, if you recall back a few months ago, there was a clear lack of alignment of federal and state government agencies in providing clear guidance. And a good example of that is to mask or not to mask. Remember way back, we were even instructed that you didn't need a mask. There were some members of the federal government who were still not wearing masks. We were told that testing is always available, to that it was not available. And it seemed as though the US government was at odds with its own health agencies at times. The CDC mandates, so the CDC was always looked up to, and then people in the United States began to suddenly get worried and very concerned and have doubts about the veracity of the information that was coming from the CDC. There was insufficient PPE. Nurses were actually beginning to reuse masks and PPE if they had PPE at all. And I'll never forget this, bandanas and homemade masks are okay. So that was not clearly something that we had ever been educated to think of or believe in. So that caused a great deal of worry and concern on the parts of staff and a part of, I would say, nurses nationally. So there are broad variations in guidelines for treatment, even within hospitals that shared the same network or system. And practitioners' treatment decisions change and vary in communication style depending on what organization they were from. And again, that lack of widespread testing certainly has the potential to stoke additional fear and misinformation. Okay, next slide, please. Maureen?
Okay, so MaryAnn has given you a nice overview, both global and national and regionally. So what were our primary issues? Certainly what we needed to look at was our testing. We had several, in the very beginning, we had one company, at least at our hospital, that was actually producing the swabs and the nasopharyngeal situation of swabbing those cases as they came into the emergency department. However, we didn't get those results back for 4, 5, and sometimes 6 days. And in some cases, we didn't get them back at all. We had to re-swab. That was obviously very difficult. We would call these PUIs, which were really patients of unknown inquiry. We weren't sure really where they sat, and we had to wait. So we placed those patients really in COVID spaces. We had to look about the demand of mechanical ventilators. For Chilton, for example, we only housed about maybe 15 ventilators. Here we now we're faced with almost 41, needing 41 ventilators. In fact, I can remember a day where we got to our very last ventilator and we weren't getting anything else from anybody else. And it was very scary times when we had to take a look at the next patient that would need to be ventilated. We were very fortunate though. The state health department had been really working very hard to get ventilators, and we then wound up getting 10 ventilators, suitcase type ventilators. Of course, they were traveling ventilators, but we were so happy to have those to be able to take care of the patients that we needed to do any kind of intubations on. And I would just remind everybody, even having to do intubations at that time was also a very scary thing. You know, where do we do that in a HEPA filtered environment? Are we aerosolizing the virus outside? So who was going to do all this rapid sequencing of ventilations and intubations? It was very, very difficult. We also then looked at, did we have enough sufficient PPE? I know that MaryAnn introduced the idea that that was also very scary. We were running short on N95s. We didn't know if we were going to have enough gowns and gloves. It was unbelievable time to even consider, would we not have enough gloves? I can remember the staff talking about that. In our particular case, it was the N95 masks. There was a lot of confusion about even wearing level 1 and level 3 surgical masks over an N95. What could we do to protect our employees at all costs? And then the last was really looking at the rooms and how we were going to design the rooms to be able to manage the patients. None of our rooms really had negative pressure. We had very few of them, maybe 3 or 4, one in the emergency department and 3 or 4 scattered around the house. That was very, very difficult also. And we had to retrofit many rooms. So I want to talk a little bit about what we did in the hospital. And it's an amazing feat about when a team can work together, what they can accomplish. And I witnessed it firsthand. So next slide, please. So at Chilton, we did a couple of things. First of all, I worked with the facilities team at the hospital, and we tried very hard to get enough negative pressures, HEPA filters into the hospital. And when we knew that we weren't going to be able to get any more, we actually contacted local garages, local paint shops, anywhere where we thought that we could actually get HEPAs. And believe it or not, when we did a community drive, we were very fortunate because the community responded, by which we actually had arrivals of HEPA filters coming into the building. And I was never so grateful actually for that coming in from the community. However, we also knew that we needed to ventilate those filters out to the air. And our materials management folks helped us to get supplies, and our facility folks actually put the HEPA filters out the windows, connected them to the outside windows by placing holes in drilling holes into the glass, being able to put it out into the air. Every room was converted really at the hospital in no time flat. We took 1 unit down and we actually just got it all accomplished to the point that we had over probably half the hospital in HEPAs, and were able to help us to manage negative pressure because we knew we wanted to protect the staff at all costs. We also looked at clustering clinical activities. It really came down to who was going to be in the room for the least amount of time to get the most accomplished and optimize the workload. And it really fell to the nurses. And, you know, it being the year of the nurse really, in my estimation, actually was the one that was going to be the coordinator and is the coordinator of care. So the phlebotomists relinquished their work responsibilities to the nurse, as did our PCTs, unless we were going to be doing a proning process for the patient. But we knew that that nurse was going to be the one sole person that would be in that room for a longer period of time than anybody else. So we grouped those clinical activities together for them. This picture that you see is our pharmacist standing out. Obviously, this is a patient that's on multiple drugs with multiple pumps. But I remember counting several patients, and they had 10 pumps running. So a lot of medications coming through. And the nurses ingeniously utilized the tubing, extended it so that we could actually close the doors, keep negative pressure in the rooms, and be be able to manage the pumps from outside, so that this way the nurses didn't have to always go in and adjust the pumps in the room. We also started to use magic marker, and we actually marked up the doors when we wanted to make sure that we had all the vital signs, so that no one would miss what the patient's vital signs were or their SaO2 level. As the days went on, we started to use white boards that you can see that's up on the wall. But early on, the staff were using any method of communication that they could possibly do to make sure everyone knew what was going on with the patients. We actually have Epic at Atlantic Health, and as a result, we worked with the state health department guidelines, and we were able to reduce the EPIC documentation processes, so this way the nurses could concentrate on clinical care. And we managed to work with EPIC to allow and encourage the nurses not to have to do as frequent documentation, but to still get the content in for the patients that were essential. In my particular hospital, we have something called AICU, which is ICU that's virtual. We have 24-hour capability of connecting electronically through a camera and with our EPIC system to ICU physicians and critical care APNs, actually out of New York. And so the nurses can turn the button on at any given time. The camera gives a really good assessment and overview and evaluation of what's going on with that patient. And the nurse can converse with the AICU group. But we only had enough for 14 beds, believe it or not, because our usual ICU is 12. We extended it to 2 more, and that was what our contract was. So we knew that wasn't going to be enough with 41 ICU patients in the house. So our chief medical officer worked with me, and we actually brought in locum tenens of physicians who, believe it or not, came from Florida and came from other areas of the country, some who wanted to really work in this situation and really get the experience, some of which felt that they had been very involved with HIV care, and they saw this as another pandemic that they wanted to be involved with. So we had 2 of them on 24 hours a day, 7 days a week, and our nurses adjusted to having those particular physicians with us. And I had the opportunity to bring in advanced practice nurses, and I ran 2 of them on every shift. 7 days a week, and it was probably one of the best organizations running in terms of having provider support and nurse practitioner support. And I also was able to bring in CRNAs who would actually do rapid sequencing of intubations, because our anesthesiologists actually happened to get very sick, and our team of anesthesiologists were not as available as we were used to having them. So our CRNAs just did a fabulous job. So really the hospital, in my estimation, was really being manned and managed actually by advanced practice nurses in all different areas of specialty. We actually, as I had mentioned about the ventilators, there also came a time where we didn't have enough pumps. So we started to evaluate patients who didn't really need to be on pumps any longer. We took them off the pumps. Only the patients who had essential infusions that needed to be titrated were on pumps. We also went out to the market and got some dialymetric flow meters, so that this way the nurses could count the drops and make sure that they were being counted as best we could use them in case we needed more pumps as well. We also looked at quick turnover of competency training for the ICU nurses. Our ICU nurses actually moved to a critical coverage of factor of 1 to 4 and 1 to 5, and we buddied them up with an intermediate nurse, or in some cases a PACU nurse or a nurse from MedSurg who had had telemetry experiences. And we put the staff through massive education on the spot, 8-hour educations, checked them off with competency, had them working with an educator over the period of time until they were very competent working with that critical care nurse. That has sustained us because our nurses transitioned very quickly into being able to take care of ICU patients, ventilation patients, high flow meter patients, whatever was the needs of the day that needed to be carried out for the patients. We also looked at, initiating some of the medications that now were going to be utilized. Certainly the hydrochloroquine that had to be started with Zithromax. We also started to do the compassionate plasma exchanges. And we're also still working with remdesivir medication and placing patients on research medication, which was also different for us. And we needed to create research nurse who would actually work there, a pharmacist and phlebotomist and a PI physician who actually would start to now monitor the patients as they were putting on research protocol, which was actually a brand new situation for us at the hospital as well. I alluded to the fact that we put in all the scrubber machines, and I talked about the IV tubing. What was really encouraging to me also is that our doors on all the patient rooms were solid wood, and you couldn't really visually see the patients in other areas other than the ICU. So we had our facility folks go around and install windows in every room so that the nurses had complete visibility to see the patients while they were caring for the patient. So as you can imagine, we did all these very quickly. We transitioned the hospital very quickly, and everything was, there was no real chaos in the building. It was very organized. It went very competently, very well. We had a lot of people walking through the organization from our system to understand how we were doing what we were doing, and we've recorded all of those because if we have to go back and do them again, which I hope we never do, but if we do, we realized that we wanted to have some plans about emergency management, not only with equipment and supplies and how we utilized our staff, but also the fact that we're now using rooms differently than we had actually even planned in our emergency planning sessions. So we have codified all those, so if we needed to go through this again, that we would be prepared. So next slide, please. So some of the challenges, I think, as I alluded to, there was a lot of fear from nurses who had really never taken care. First of all, there was fear from nurses in general about the unknown about this pandemic. And of course, in the early parts of this, we weren't sure if this was droplet. We weren't sure if this was aerosolized. Infectious practitioners couldn't really give us a complete read about what it was until, as time went on, we could actually get more of an understanding about the value of the PPE and the N95s and the idea that we had to protect ourselves. We had to put protocols in place for the nurses to understand how to don and doff. We gave them videos. We gave we put team members on the unit to help them don and doff correctly because at all points we wanted to make sure we prized the staff to be well equipped with PPE. To Atlantic Health System's credit, it never ran out of PPE. It never ran out of masks. Did we ultraviolet some masks over time? We did, but for the most part, we were very lucky in that we had everything that we needed to at our fingertips for the staff. We also, the intermediate nurses now needed to learn how to be critical care nurses, and the PACU nurses needed to learn to extend their skill sets beyond PACU. As I said, they went through the classes, but I think they got immensely educated by working one-on-one with their critical care colleagues. In fact, I walked into the PACU setting, which would be a non-COVID environment that actually had same-day surgical nurses and nurses that worked in pre-admission testing and nurses that worked, I think we had one PACU nurse, and we asked a critical care nurse to come down. And as a result, they were able to staff 10 to 12 of those ICU patients. It, to me, was just an amazing representation of nursing rebounding and working together collaboratively to learn from each other. We also made sure that we implemented strategies on our med-surg and intermediate units. For the most part, our staff there had to take care of other types of patients that were still in the building, although one by one, each floor started to turn COVID. So in the end of the day, we only had one unit that actually never got to be a COVID unit, and they became an intermediate unit from being a med-surg. When I went to close the PACU down, because as we were reversing out and we weren't having so many patients, I wound up transferring 14 ICU patients to a floor of intermediate, and one by one we started to take care of those patients on an intermediate unit because we needed extra beds. So when I tell you that the staff mobilized from unit to unit and mobilized from shift to shift and mobilized from ICU to intermediate, honestly, we kept track of it every day, and the staff did a fabulous job with that. So next slide, please. Now I'm going to turn it over to MaryAnn.
Oh, sure. Thank you, Maureen. And so much, in terms of being able to jump through hoops and rise to the occasion, as Maureen's saying, has a lot to do with with leadership. So through Maureen's leadership and the leadership of her team, we were able to put together this plan related to the preservation and improvement of the nurses' coping skills. So some of the things that we rapidly and quickly, of course, recognized what was distressing to nurses was everything that we just mentioned. And I'm sure all of you who are listening and watching, you're each reflecting about your own experiences and your own organizations, and how much you've all been through in this short period of time is really staggering, you know, when you think about it in our lifetime. So as Maureen started to talk about and was speaking about, is we almost got to the point of participating in allocation decision-making, right? About who gets the care and who doesn't. We were not at that point, but we know that there were other organizations, and in New York City, of course they did, were worried about who was going to be cared for and who was not. We certainly managed surges in census and increase in overall acuity of patients. So for nurses, as Maureen said, who are accustomed to working in an intake area or in PACU, who had not taken care of very, very acute care patients suddenly were. They were also coming into contact with patients whose conditions were rapidly deteriorating. And I remember clearly the first group of nurses that I was speaking to at a meeting, they were emergency room nurses, would say to me, "MaryAnn, this patient came in," and then before you know it, they were short of breath, and then next thing you know, they were on a vent. So that rapid deterioration, right, of the patient's condition was very striking to nurses, and they were having a very hard time in managing and processing that. Of course, everybody who's listening and everybody who has been working in a hospital over the past several months understand and realize that patients had been separated from their loved ones and families, and even at the end of life. So nurses were the ones, or are the ones, who are maintaining that human touch with patients at the end of life. Often Maureen orchestrated getting the iPads in so that they were used for this purpose. And in conjunction with our chaplaincy program, we're able to bring the priest, the rabbi, or the minister with them virtually into the visit and into the room with the patient, and then have prayer with the nurses at the bedside. Certainly we're all used to dealing with death and dying, but not to these numbers or this impact. We, as I'm sure you did, had presence of morgue trucks outside the hospital. That was your daily reminder of the volume of patients who were passing from us. And then the nurses themselves, for the first time, because of the infectious nature of the virus, had a fear of contagion, of being infected themselves, perhaps becoming very sick themselves, and then being separated from their families. And I remember rounding on a particular weekend where a nurse said she hadn't seen her children in several weeks, and it was starting to have that impact for her. Next slide, please. So when you talk about the high potential for what we call residual psychological issues, what we mean by that would be the issues that really linger, the ones that perhaps as nurses or caregivers in general would be telling me they'd be driving home and all of a sudden have to pull over at the side of the road because they were just overwhelmed with the feelings that were coming up during the day for them. So individually, though, I have to say staff may have had prior experiences with their own anxiety, like an anxiety condition or a panic disorder or depression. And all of a sudden they're seeing symptoms reappear that they had not had trouble with since they were working as a nurse. And they were thinking, oh my gosh, I haven't had this panic disorder or this anxiety problem since I was way back in college, or dealing with a separation or some other situation, and here it is coming back again. What do I do? So that was particularly common. Particularly concerning or troubling is if the nurse had no prior history of anxiety or panic disorder or depression or sleep, and was starting to have symptoms and saying, again, you know, what do I do? So one of the things that we always worry about, of course, is when we deal with someone who's about to undergo psychological trauma, which is what this is and was and is, is always the threat of infection, which is underlying there, as we said, infecting yourself and perhaps infecting others in the family. So anecdotally, I saw staff, I know Maureen rounds all the time, we both saw staff trying to process this very, very rapidly and certainly rising to the occasion, while also struggling mentally and psychologically to adapt to the what we always call the new reality. What is our new reality in terms of healthcare and as citizens in the United States? Again, always that undercurrent of fear and panic. I do think that there's a paper in this for anybody doing a capstone about how generational I truly saw this, that the mid to late career nurses certainly seem to adapt fairly quickly, with the late career ones having the most concern, particularly if they had not been involved in the classroom situation in a while or in a high acuity situation. But that was only equal to by the early career nurse who had absolutely no context for all of this. And I was in the emergency room on Monday, Maureen, with Dr. Bolo. And I said, you know, for many of us, we've survived H1N1 and the threat of Ebola and even the AIDS epidemic, et cetera. And Dr. Bolo said to me, MaryAnn, look around. Do you see anybody else in the room who's been through the AIDS epidemic besides you and me? And I said, yeah, you're probably right. So there's a lot of early career nurses out there who have, again, no context. So when Dr. C was talking about, he was quoting movies a lot, the good, the bad, and the ugly. Well, the good part is that anyone who's infected with AIDS, that was on my mind, with COVID-19, about 90% are home, right? And they're worried well, they're diagnosed and they're recovering at home. And of that whole amount, 19% are healthcare workers who are infected. And so far, tragically, we've lost somewhere between 27 to 30 healthcare workers as of April. So the ever-present reality does wear upon you over time, thinking, well, hopefully that will not be me. Next stage, please. Next slide, please. So Maureen and I were truly informed by 2 articles besides this one. And that was very, very early on. Again, going back to the slides, we would have put together our plan very, very early on into the pandemic here. So the 2 articles that really helped us, one had to do with the incidence of MERS in Saudi Arabia, and the other one originating in China, which at the time of our collaboration on this were really the only 2 articles we had to review. But we were both very well familiar with the trauma literature and the value placed upon awareness, so at the point of care. So, you know, why do we say this? Well, according to the United States Department of Veterans Affairs, PTSD follows when there's extreme or unprecedented life experiences that lead to, quote, haunting states of inner conflict and turmoil. So it's not so much the patient who is dying, because again, we're all trained to deal with death and dying. It's a few things. One, it's giving up on patients who would ordinarily have other avenues to pursue, and this was not really the case in Atlantic or at Chilton, but certainly was the case in some of our high-occurring New York City hospitals. Many patients were and are elderly, but a good number were in their 30s, 40s, and 50s. So that gave the nurses more fear, because generationally, they could certainly, we could relate to those age groups. And then the last part is where nurses we're working extremely long shifts with little breaks or sleep to be able to process what may prove to be in the long run, so what they call a moral insult, you know, when you just can't reconcile what you saw. So the slide here was, again, our colleagues in China really went right to the books and right to the laptops and computers and wrote down so many things that were very helpful to us. So similar to the stages in death and dying, they saw that when they did their phenomenological study about nurses who were dealing with, and caregivers in general, who were dealing with all the pandemic over there, was that of course they were tired, so fatigue, discomfort, and helplessness. Of course, they were trying to immediately deploy whatever worked before. Could it work now? You know, self-coping styles. They did see in a positive way, very similar to what Maureen is describing, nurses rising to the occasion, growth under pressure, professional responsibility, opportunity for self-reflection. And then number 4, positive emotions, which seem to occur in concert sometimes with negative emotion. And particularly with the early career nurses, that's one of the things that they'll tell me. Again, when they leave their shift or perhaps in the middle of the shift, they're thinking positively, like, wow, look at all this great work I've been able to do, along with the negative. This is so tiring. I don't know how I can go on for my next shift without a break or without a day off. So we talk about taking a day off and supporting you in some way. So the next slide is this whole idea of work-life balance. Again, these are some of the things that made it very difficult for our nurses, especially the younger nurses, the early career nurses whose families were worried about infection. So they removed themselves and went to live with a mother-in-law or a grandparent and left. And one nurse said to me, when at the end of my shift, I go home to a cold, dark, empty house. I want my family to be with me, but I understand why my family can't be with me, as the tears, you know, come down a little bit. So what we talked about was having some more opportunity for FaceTiming and Zooming and all of the other things that could be helpful to maintain those contacts in some way. So again, all of these things we talked about before. Some of our nurses were self-quarantined in hotels, not even at home. And again, little to escape from, you know, the grueling shifts at work. So when you think about some of the things that our nurses were worried about, it's the very same things that staff and nurses have been worried about all over the world. You saw the pictures of the nurses in Italy and the nurses in China, and everyone was quite exhausted at this particular point. Okay, next slide, please. And on top of that, any of these faces look familiar. As nurses returned home from work, and especially for those living with families, what did the families do? What did they have to do when they were home quarantining? Keeping the television on all day, right, with the news. And one of the first things that we would do in our newsletters and that we released, which we'll go into in a little bit, in our huddles and our rounding, would be to say, try to minimize the news, and why not shut it off entirely? So one of the statistics that I saw there was that 95% of Fox News coverage from March 12th to April 10th was related to COVID-19. 90% over there at CNN and 80% at MSNBC, meaning that the vast majority of news had to do with COVID-19. If you turned on the television to the news. So again, the nurses would say to me, I feel like I'm at work, or I feel like I left work because I go home and then my family's, you know, badgering me and asking me so many questions about how many patients did you take care of today? And were you careful enough? And did any of your coworkers contract the virus? And one of the nurses actually said to me that when her family says, did you take care of COVID patients today? She would say no. It's because she didn't want to get into that whole discussion about, well, how many patients and were you safe and all of that. So the families were naturally and understandably worried at that point. Okay, Maureen, next slide.
So just simply put, on March 23rd, it became very clear to me that I needed to address the emotional needs of the staff. And you could tell, as MaryAnn is describing, the staff had many, many different interventions that were required because they were all really suffering in many ways. So my goal was to actually work with MaryAnn and identify opportunities for her to become very influential in really trying to work with resiliency with the staff. And I could find no better person than her to actually be available, to actually work one-on-one with the staff, to work in huddles, and she's going to describe some of that. But the plan was to really work with our staff in any way we could to get them supported and intervene for them so that they could go on from day to day to provide the care to the patient and still have resiliency in what they needed to accomplish for themselves on a personal level. So MaryAnn, next slide, turning it over to you.
Sure, thank you. So we developed the plan, Maureen and I, and all the things that Maureen just mentioned is the huddles, the newsletters. We'll give you some examples of those. Maureen, early on in her magnet journey, brought in the use of the Gene Watson Caring Room and Gene Watson Philosophy. And we have an outstanding, absolutely outstanding employee assistance program called Concern in Atlantic Health. That contains just about everything and anything that you would want. So this was really a plug-in to a fantastic, fantastic services. Next slide. Because we quickly realized that there was a need for us to be very, very up close and personal with the novice nurses, we had drop-in sessions for them. What you see there in the slide is the old coffee shop that was under renovation, but we quickly took it over for our uses. Reviewed self-care interventions and critical care courses. We met up with the orientees on a one-to-one basis, went through unit huddles, and gave intros to these agencies and traveler nurses who, as Maureen said, were traveling from all over the country. Next slide. I think one of the biggest discoveries that we all know as nurses is that very rarely would staff ever reach out to a 1-800 number to telehealth or telepsychiatry as a first line of health. They're just not going to do that unless they were in truly desperate states. And by then you would say you missed an opportunity to intervene a lot more quickly and timelier. So Maureen's wisdom here in having me be available to do this was really very, very key here. It was said on one of our early morning 6:30 calls, Maureen, where someone said, you know what, caregivers respect other caregivers. And they felt that it was important to have someone who was a nurse who was available there. So what I did then was introduced topics of, you know, what symptoms you might be feeling, and you might be feeling this right now, as a matter of fact, as opposed to, as I heard from some of my colleagues around the tri-state area say, well, we have an EAP, they could always call that number. And we felt that that was a little cold and would not necessarily address the needs at the moment. So what we try to do then, and from a psychosocial point of view, is to normalize their staff response or their own individual response to what certainly is a very abnormal situation. Nothing in nursing school can prepare you if you're a brand new nurse to what they were suddenly dealing with. So we felt that it was important to educate and also very, very lovingly reach out to the nurses. And there were many days where I reached out to I keep saying nurses, but Maureen was also very clear that we reach out to dietary, to housekeeping, to pharmacy, respiratory, major need in respiratory, to make sure that, and I'm sure I left out a few departments, but to make sure that we rounded in all of those areas as well. For example, the morgue truck was right outside the loading dock, and guess what? That's where dietary is for the most part, and that's where staff come in and out of. So there was some need there to do some debriefing with all manners of staff. I gave everybody my personal cell phone number, and then some of the staff actually asked me if I would check in on them on a daily basis, and they would check in with me to let me know that they were okay. So I thought that was a great thing to be a privilege to be part of. Next slide, I'll turn to Maureen.
Well, really the next slide in a condensed version is really about mental health awareness. And this was probably one of the focus times that really this was going to take precedence also to support our staff. However, I think what you're going to find is the next slide, which MaryAnn took. And MaryAnn, why don't you just talk a little bit about what that picture means? It's so precious.
Right. Thank you. Well, this is a very important slide, the next one for me, a very personal one. And this is obviously those of you who are there in Boracay will certainly recognize that as being such a beautiful, beautiful scene. It's such an amazing privilege and opportunity for me to be invited there with all of you. But the quote that I wanted to assign to that beautiful picture is about your mindset, and the definition and what does resiliency really mean is about adjusting your mindset to a brand new reality. And none of us know as American citizens what our new reality and global citizens, what our new reality will even consist of. We don't know that. So it's all about when people change to a growth mindset, you change from putting things in a box and thinking as though you have to live there to a learn and help learn framework. And as this author says, our commitment should be to growth, and growth takes plenty of time, effort, and mutual support. So it reminds me of that little cliche, you know, there's no I in team. It's all about how this is really a group, a team sport, and how we can get through this at the local level means relying on one another when we can get there. So thank you, Maureen. I'll turn it back to you.
Well, the next slide really is about myth busting for resiliency. And there were 3 areas here that really need to be myth busted. One is resilient people don't experience negative emotions. Certainly they do. Truly resilient people allow themselves that experience, their full emotions. They go through the whole gamut and the whole continuum. They talk things through and they help to identify hot spots, and they actually reach out to others for assistance. Resilient people go it alone. Well, certainly no, they don't go it alone. They truly have an enormous social network. They call each other, they call friends, they social network. We know a lot of social networking was going on during this period of time. We could see it every day where people were trying to really connect with each other. And resiliency is a trait. You either have it or you don't. Of course not. Reality is that truly resilient people develop skills, attitudes, and of course behaviors that can be worked on. They're developed at any stage of life, and we're always developing them during our stages of life, and certainly during any life journey circumstances that change our lives. So now I'm going to turn it back over about mental health facts.
Well,
MaryAnn.
thank you, Maureen. So you heard pretty much the things that are within my repertoire as I approach staff, and no matter what level they're at, and no matter what unit or department and who they are, is to really think about yourself. And one of the popular things that I learned early on in mental health, as I said, when I used to do this job every day, was more along the lines of, you know, make sure you put oxygen on yourself first. That you can't be any good to anyone else unless you take care of yourself. So that's very key. So one of my questions would be, well, how much did you do last night? You had less than 7 hours, less than 6 hours, less than 5 hours. We know from the literature that that's equivalent to driving drunk. If you get less than 5 hours sleep and by the middle of your 3rd shift, it's equivalent to driving while impaired. So it's really important to get that sleep and rest and restoration. Just limiting social media and limiting how much you engage with other people, especially on Facebook or Twitter or any other platform, who are critical of you because you're a nurse or because you're a physician. And there's been bad stories that have happened where people say, you know, you're making it up, there is no pandemic, things like that. And why do that? Why do that to yourself? Just disconnect, detach from that, and focus more on the care of yourself and your healing. Giving time for your grief, for coping and caring for yourself. And one of the other ones that I've said when I was speaking to, again, an early career nurse, you know, no pandemic decision making. So now is not the time to make a major career change or relationship change that's based upon fatigue or sorrow or loneliness or not being in your right frame of mind. So certainly that would not be a good thing. One of the things I always advocate too is to get a caring buddy on the unit. And this actually happens in the ICU, where a nurse said, I feel as though I'm kind of losing touch with myself. So I asked my colleague, her right there, and she and I are going to watch out for each other to make sure that we're okay. We're going to check in with each other on our days off. And I thought that was a great example of caring and collegiality. Another thing that I heard early on, you know how we always talk about social distancing, and there's a concept which is consistent with religious and moral thinking, which is called social solidarity. So I challenge everybody tonight to make that switch in our verbiage from social distancing to social solidarity, because it brings us more together to think of doing things that works well as a team, as opposed to that distancing and pushing back. So that's, I think, an important thing to think about as well. Some people, and again, I'm one of them, I can't read enough, I can't learn enough about this coronavirus, and I just love that the Dr. C's lecture last week. I could listen to it, I probably will a third and a fourth time. So if you feel as though you want to take some online courses, why not do it and get credit for it, but also know when to turn that off and just listen to radio or a comedy or something else on TV, which is a little bit better. Next slide, please. I'm also a big advocate in these apps for your phone, and I personally have recommended that Calm app. It's over in the upper left-hand of your slide there. There are sleep stories, there's relaxation tips, there's all sorts of things there. We're a member of Atlantic Health in the Schwartz Center, and there's absolutely tons of resources with them. They just had a webinar on healthcare professionals coping with COVID-19. The ANA does, and look at you, PNAA is doing that as well. So that's really awesome that there's so many web-based apps and podcasts available, and to take advantage of them. Okay, next slide, please. So one of the things I also quickly realized when I touched base with Maureen's organization is how really they utilize the Gene Watson caring theory and everything they do. So I thought, let me see if I can help a little bit. And in keeping with the teachings of Dr. Gene Watson's Caritas principles, next slide, please. We work together to revise our daily huddle format. So this is really the format that you have in front of you. And we go through this at the 7 a.m. night shift to day shift change. So before report happens, before anything goes on, this is the opportunity for the night charge nurse to turn over, as I say, the whole unit in a big red bow for the next shift. So we actually had the opportunity to present this to Dr. Gene Watson, who totally loved it. So there's a good thing there. And it is fun to be able to introduce this to a team and then have them come up with a quote, which is super awesome. So this morning, I was actually on 2 East, I believe, and that was a great opportunity because you really get to see them with this moment of silence and pushing out that loving kindness to each of them and for themselves. Next slide, please. One of the things that I find too, of course we all do, is that just because you have a psych APN walking around, does that mean that, you know, I walk around with a couch or a chair where people can just sit down and just unburden? No, it might not be at the most opportune time of their particular day. But you know what? We found that with distributing these little newsletters that we created, my cell phone number is on each of those. Really focusing on caring for the caregiver on one side and some mental health check-in tips, and on the other side there's a review of some of the opportunities that Atlantic Health System provides, such as the Watson Healing Room concern, links to workplace, and they have a whole page within our workplace app, which is the organization's Facebook page for internally. So that I felt that was a good thing for them to have. And you'd be surprised they'd turn up in all the units too. So that was a good thing to do, we felt. Okay, next slide, please. Okay, Maureen, do you want to go through that?
Well, I can do this one. The virtual appointments, I think MaryAnn is just alluding to all of the opportunities that we have for our staff, but wherever we could connect with the staff, wherever we could make an appointment, wherever MaryAnn could actually talk with them, that was what was important to them in terms of getting a one-on-one touch point or getting group therapies, whatever would connect with them. And certainly using, even in the hospital, we used our employee assistance group as well for mental health and mental wellness. Everything was of importance. We also, of course, were concerned about employees. Next slide, please. That actually, also we had a good number of employees that turned COVID positive during this period of time and had to be out for extended periods of time, many for 4 and 5 weeks. So during their time while they were out, we actually touched base with them at home just to make sure that they were knowing that we missed them and hoping that they were doing okay. And upon their return, we made sure that they were brought up to speed on what had changed during their period of time, because we were changing every day. We wanted to keep them alert. We also wanted to ingratiate them back so they felt that they were part of the team and felt comforted by that. We used every opportunity we could to extend Jean Watson's caring program to them, even stopping and talking to them, including them more and more into any facet that we could so that they were feeling comforted. Next slide, please. We also realized that resiliency huddles with psychiatrists. We actually have our psychiatrist that's on staff who actually became our resiliency guru, if you will, even with our physicians. And he now is co-adopting, in my humble opinion, MaryAnn, moving through the building and actually working and meeting with different members of the staff. So he's met with ICU, the emergency department, respiratory therapy, and continues to have a growing list. And they both go out now and they start talking to the teams collaboratively. I think he has really grown to understand MaryAnn's skill set and the ability to utilize and leverage what she understands about nursing and what's patient care. And they've made a very good co-team together. And they also provide another emotional support for all staff. And I would say even to the physician staff, we wanted to make sure the staff and the physicians were working and getting the same kind of resiliency and support together. And we were advocates for resiliency. And I have to say that MaryAnn and Dr. Bolo, who is the physician, has done a super job with that. The next slide, please. What I wanted to share with you is that this was a very poignant picture that was outside one of our hospitals, which was a man who dropped off his wife actually to the emergency room. And if you can see what the poster says, he basically is thanking them for saving his wife, the life of his wife, and that he loved all of the staff, all the nurses. This was probably a very heart-wrenching thing for him to have to be outside looking in, us looking out and not being able to include him in the care, but try to do everything we could in terms of using iPads, telephones, whatever would work so that the communication, actually we even had a set of nurses that would reach out to the families twice a day to keep them as informed as they could. But again, hard to be on the outside. Next slide. And then, of course, we had signs of hope. You'll see here on the slides, on the left-hand side, we actually had staff that actually depicted where we were in this pandemic in terms of how many patients we extubated, how many patients left the building, how many patients we had in total. You can see in the middle slide are patients that are leaving and going out, thank goodness to the staff, and feeling supported as they rolled out to a rehab center or to home. And then we also have on the right-hand side the great support we have from our community, tons of donations, tons of support, tons of letters, tons of social media, thanking us for all the care that we were delivering in the community. And I'm going to turn it back over to MaryAnn for this last slide.
Oh, thank you, Maureen. So this next slide, those of you who were actually with all of us in that beautiful conference in the Philippines in January, that this kintsugi is actually called the art of precious scars. It's a Japanese tradition. And this means golden journey in Japanese. And if you look closely at this is a bowl, you will see that this beautiful bowl is a treasure, not because it is in one piece, but because one day it was broken. So it is highly valued now, more highly valued now, because the gold that they used to mend it draws attention to what was broken and is now healed. So as we, as a profession and as a nation, start our period of recovery and we start to heal from this terrible scourge, let's also remember what it took for us to get here and how resilient we truly are. So I just want to thank Maureen Schneider for the opportunity to work with her so closely over this past year, to have this opportunity to help in some way with the staff at Chilton Medical Center, and of course, my dear friends and colleagues at the Philippines Nurses Association. So thank you so much for the opportunity to allow us to present here this evening.
And thank you to MaryAnn, because she has been a wonderful asset to Chilton Medical Center and a colleague and a great person to be bouncing ideas off. So she wound up being a little bit of my resiliency too.
Oh, thank you. Thank you, everybody.
To all of my colleagues also at the PNAA, I fondly remember you, working with you, and I still know how much support that I have for you and what you did every day during this pandemic as well. So my graciousness to you as well. Thank you very much for the opportunity to meet with you and talk to you.
Thank you, Mary and Maureen. If the two of you were in the government, I'm sure we'll be in a much better place now. The chat monitors now ask the questions.
Okay.
MaryAnn and Maureen, you compliment.
Oops, we lost the audio. I think we lost her audio.
Yeah.
Oh, Maureen and MaryAnn, I said that you complement each other, and I'm very happy that the nurses and everybody's working in your facility, because I envy them, because I know how it is to work with you. Thank you so much, and again, I just wanted to tell everyone that both of them are our PNAA honorary members, and they've been supporters forever and ever, and we love them so much.
Thank you so much. Thank you. Thank you so much. You know what we forgot to say is that Maureen and I have a publication coming out in My American Nurse. So we expect that to be coming out in the next couple of weeks. And this is pretty much what this presentation is. So thank you for that.
And I have time for one question.
Encouraged all that. So thank you, MaryAnn.
Thank you.
Chat monitors, I think we have time for one question.
Okay. Thank you, Dr. MaryAnn, Donohue-Ryan, and Dr. Maureen Schneider. I'm Manny, and I'm going to read to you one of the questions. In the case that a resurgence of COVID-19 hits the U.S. next winter, what are the priority areas of concern that need to be addressed related to caring for the caregivers?
I would say just at Chilton anyway, thank goodness we have enough equipment now, and we have enough PPE, and we now have a good roadmap for our journey in terms of the units and ensuring that. I think it's really, MaryAnn, I think had said this a little earlier in the presentation, is bringing the staff back for round 2 of this. Round 1 was very, very tough, and many of them got through it through the crisis of the moment. Now they know what's going to come forward again, some of which will, I think, do very well because they've had experience with it and they can adapt to it. But I think there's going to be a group of people I worry about with PTSD syndrome, I think, going forward, because they don't want to relive this again. And in some cases, it's been nightmares for them and also for their families. So I think, and I'm going to bounce it over to MaryAnn, but I think it's how we're going to make sure that we support the staff through a round 2 situation.
Yes, I definitely agree with Maureen there. And we have some vulnerable groups that we have to really not forget about, and that would be the new graduate nurses, right, Leo Gerardo? The ones who were in New Jersey, at least, were given a provisional license to practice and maybe just a little bit overwhelmed at this particular point and need some bubble wrap around them to be able to help them process through this entire experience. I also think, thinking with the glass half full here, that we're actually inspiring a whole future generation of nurses and caregivers who say, I want to be a nurse just like that nurse who went in facing what he or she had to face. And I've certainly heard my share of those very inspiring stories. So you, my dear fellow nurses, have inspired an entirely new generation of nurses coming forward too. For sure.
Agree.
That winds up our presentation. There's another piece later. I would just like to thank Maureen and MaryAnn, our friends in PNAA and PNANJ. A wonderful thank you. Everybody, jazz hands, please. Jazz hands.
Salamat po. Salamat po.
Maraming salamat. Thank you
for a
so
great
much.
journey, a great experience. Thank you.
Thank
Thank you.
you.
Love you.
Thank you.
And Dr. Maureen and Dr. MaryAnn. Leo.
Leo, how are you? Hey, listen, I saw you on TV the other day. On Fox, you look great.
I heard.
New Jersey is so famous.
Yes.
We have
I'm so glad that you
congratulations,
guys,
New
You did a good
Jersey.
job.
I'm so glad that you guys put this out for publication. I was just texting MaryAnn, put this for
You did. I saw your text. Yes. And that was it was so interesting. Are we offline now? Just the group of
It's
us?
okay.
No, we have another mindfulness after this.
Oh, so there's
So
the whole country.
you go do a sidebar, the three of you.
Okay. All right.
I'm sorry. All right.
Carol, can I share screen?
Okay. So now we're moving into the next part.
Yeah, mindfulness.
Mindfulness. Okay.
Yeah. Hang on.
How long is-
We have mindfulness.
Okay, hold
Coming
on,
up.
May.
All right.
Go ahead, May.
Okay. So now this is the part where we relax PNAA. Our next speaker is April Frazier-Wong, BSMS, and she will take care of our body, soul, and its healing practices for nurses #2. And as of the other week, this is last Saturday, I already, we did part 1 already. So nurses are at the heart of healthcare, and it's important that we care for the heart. Mindfulness is a practice of bringing non-judgmental awareness to the present moment. You will be guided through practices anchored in breath and body awareness to support and care for yourself as you care for others. April was part of the inaugural cohort of the Spirituality Mind-Body Institute at Columbia University, where she received her master's degree in spirituality and mindfulness in 2016. She got her master's in education at Fordham University and BS International Relations, Community Development and Educational Studies from Mount Holyoke College. Take it away, April.
Hi, happy Saturday, everybody. It is a blessing and an honor to be with you all for the second week. And I love this idea of being not just part of your self-care plan, caring for the caregivers, but also your resiliency plan as well. It's a blessing and it's an honor. So much of what was already shared is such a beautiful transition into the practices that I will be inviting us into this evening. This idea of how do we care for ourselves when so much is unknown, right? And so much of what is unknown is when we really get into the thinking mind, right? So much of what is unknown is what's being shared with us in the news, perhaps, and a lot of that feels unclear. But right here, right now, in this moment, what is known is that you all did make a choice to be here, and we are in our breath, and we are in our body. And so why not tap into how that is feeling for the next half an hour or so to be your greatest resource for resiliency and self-care. So that is an area of certainty that we're going to explore this evening. The second piece that I really loved hearing about was how strength for nurses during this really difficult time lied from within. so much of the resources came from within the nursing community during this time of uncertainty. Now with mindfulness, you get to take that even further by not looking outside of yourself for your resources for self-care and resiliency, but it's really going deeper within yourself, breath and body, to find what resources lie within you to heal whatever lies there within your experience. Breath, body, and release. So that's another part. The second part, which I really, the third part, which I really loved hearing about, is this idea of over bombarding with news, right? That's a real thing that all of us are going through right now. And the only news channel that I want you to turn on in to right now for the next couple of practices that we engage with is our minds could be like news channels. And the channel that you're going to turn into right now is turning into the channel of what your body is telling you. Turning into what your body is telling you and how it's feeling. We're going to go through some relaxation techniques. And the last thing is everything is welcome. What was really nice to hear from Dr. Schneider and Dr. Donohue-Ryan was this openness to whatever feelings that you all are feeling in this moment. Anger, frustration, stress, whatever it is, it's all welcome, because we don't want to silence anything that we're experiencing, because then that will lead to more stress later on. So everything is welcome here. Okay, so let's get into it. I want to give you all a minute or so. I don't know where you all are calling in from or the space that you all are calling in from, but I wanted to give you all a minute to, as we take time and space, to set up your space in however way you can feel comfortable. So whether you have the capability to grab a pillow perhaps, or a blanket, or maybe you're in an office space and that means for you dimming down your lights a little bit. Maybe that's not, maybe it's just loosening up your belt or loosening up your ponytail. Maybe it's turning off your video if like having your video on Zoom makes you feel like you have to like stay present more in this and you can't turn off. You could do whatever it is to make you feel comfortable. All right, and then we're going to get into our practices. Very good. Yes, whatever makes you feel comfortable, we will do that. Yes. And then when you hear the sound of the bell, that's when we will officially get started. So I like to set up my space with like some sort of pillow, a blanket, wearing something comfortable perhaps, because you can always take these practices outside of here and do them later on as well. So just start to still the body and draw all of your awareness to the sound of the bell right here. And when you can no longer hear the bell at all, just raise one hand in the air. And notice that the body comes into stillness to hear it longer. Good. And you slowly bring the hand back down. Now, when we're in a position of feeling anxiety and stress, we contract. We close off our heart and we get smaller. And when we're in positions of service, we sometimes make ourselves smaller as well. There's this whole thing of power posing. So I actually want us to start there. There's two that you can choose. You can bring your hands behind your head. The biggest thing you want to do is to puff out your chest. Get expansive through your chest. This is called the CEO, the boss. It brings confidence from the body to your mind. Expand through the elbows, widen through the chest, maybe close down the eyes, drop out of the chatter of your mind, and drop into your heart center. Good. And now, silently think to yourself as you hold this power pose, there is no fear in my body. There is no fear in my home. Now wrap your arms around yourself in a gentle hug. Bring your chin towards your chest and rock yourself gently left and right, kind of like the gentleness that you would rock a newborn child. And think to yourself silently, there is love in my body. There is love in my home. Good, let's do that 2 more times. Power pose, puff out your chest. Allow yourself to take up space. There you go. Silently think to yourself, there is no fear in my body. There is no fear in my home. Wrap your arms around yourself. Gently rock yourself left and right. Right now, there is love in my body. There is love in my home. Last time, power pose it. Puff out your chest. Allow yourself to take up space. Body sending message to mind. Confident, strong. There is no fear in my body. There is no fear in my home. Wrap your arms around yourself. Gently rock yourself left and right. Right now, there is love in my body. Good. There is love in my home. Good. Slowly come back up to center. Now think of all of those anxious thoughts. They lie right at your mind, right? Now you're going to feel as though like you're scraping them out of your head, out of your mind. Feel the fingertips press against your forehead, and then you just flick them out to the side. Yeah, kind of feels good. 4 more like that. All of that uncertainty, just feel it right through your forehead. Flick it out to the side. 3 more. Press down into your forehead. Flick it out to the side. 2 more. Really feel the pressure of the fingertips on your forehead, through your temples. Flick it out to the side. Last one. Good. Flick it out to the side. Now, last little bit here. Gentle massages up your arms. Now, we live in our bodies and we move through the world in our bodies, but it's interesting how disconnected from our bodies we can actually be. So really feel this fully. Really massage down the arms, the wrists, the hands. Silently think to yourself, thank you, body. Thank you, body. Thank you, body. Feel it more than think it. Maybe above the eyebrows, the temples, right by your collarbones. We hold these little pockets of sorrow and tension right there. Can you have your own back? Massage down your back. Good, the legs, the knees. Good, the feet. Good, that's it. Now here's one of my favorite ones. Now think of that maternal touch. I call them mom hands. You know, like when a child is in distress, we think about like that loving touch a mom does on a child's back with the circles. Circles calm down the nervous system. So take one hand onto your heart The other hand onto your belly. Circle. Heart. Belly. Good. And the body is receiving this message. And the mind is receiving this message right here, right now. You're trying to take care of it. You're trying to take care of yourself. It's a practice, not a perfection. It's a practice, not a perfection, right? It's a practice, not a perfection. And then you circle it the other way. Gentle circles. Gentle circles. Good. Circles just calm the nervous system down. You place the hands onto the knees and you take that circular motion with the neck. No forcing here. Just let the weight of the head carry the neck around. Yes. And like the heavier your thoughts have been, the more the mind has been moving quickly, the heavier you allow your head to be. And you just circle it around. And then you change directions. Just let the weight of your head carry the neck around in big circles. It really does not matter what it looks like. It just matters what it feels like. Good. Circle the shoulders. Weight of the world. Let it go. Circle them the other way. Circle the torso. Just circles. Good. And even if nothing is changing, you can't think your way through a lot of this stuff. The body is starting to send a message to the mind eventually, that right here, right now, we're doing something that is feeling okay. It's feeling good. Right here, right now, we are trying to do something to release some of that stress and tension. The mind and the body are trying to be friends again. And just like any relationship, it takes time. It takes time. Yeah. It takes time. It takes listening. Yeah. Good. And slowly come back to center. And now for this part, you're going to come into a really comfortable position. I'm going to turn the lights down. A couple of things I'll invite you into. Lying down feels really good for this one. And I'm on East Coast, so it's late. If you want to fall asleep, I won't tell. Feel free and wake up on a Sunday. If you're on another time zone, take a nap maybe. A couple of things. So our joints store a lot of trauma in our bodies. If you have lower back issues or anything like that, you can place a pillow underneath the knees. You can also place like your legs up on something. If you tend to have a fast-moving mind, something weighted, like a blanket or something like that, or even like a book, something on your body or a pillow that is literally weighing you down can help support you. If you don't have anything like that, I've noticed pressing your hands like down onto your body can help feel like you're grounding yourself down here. Because sometimes when the body comes into stillness, it's different. The mind will sometimes want to move more quickly. All right, so come into a comfortable position and I'll turn the lights down. You can do the same thing. And I'll light a candle for you all as well. And I'm going to guide us in a beautiful body scan. And it's a tense and release body scan. There you go. And this practice really helps us start to build more awareness around the different sensations that we store in our bodies and letting some of that tension go without judgment. Without judgment. Good. If you notice the mind starts drifting into thought, It's okay. It's what the mind does. You can silently just think to yourself over and over again, I am relaxed. I am relaxed. Good. Notice your feet. First, tense and squeeze your feet. With the exhale, release. Relax the feet. Good, good. Squeeze the muscles of the legs. Hug the muscles of the legs towards the bone. Good. With your exhale, soften, release, relax the legs. Good. Squeeze your seats. Relax, release your seat. Good. Tighten your belly. Clench your abdomen. Good. Soften, melt, relax your belly. Good. See if you can squeeze all the muscles of your back. And then release, relax, heavy the back. Good. Clench the hands into fists, squeeze the arms, the biceps, clench, tense. With the exhale, relax, release the hands and the arms. Good. Squeeze the shoulders up towards the ears. And with the exhale, soften, release, melt the shoulders away from the ears. Good. Clench all the muscles of your face. And then release all the muscles of your face. Relax the jaw, tongue heavy in the bottom of the mouth. Eyes sink back into the head. Good. Just leave the body by itself. Leave the breath by itself. Enjoy the journey. The sound of the bell will wake you. Slowly begin to come back if you like. You don't need to. Maybe gentle wiggle of fingers and toes. If you'd like to awaken, you can stretch like you're waking up from the nice, long, luxurious nap. If you're lying down, you can bend one knee, maybe roll over onto one side. Eventually coming up into a comfortable seat if you'd like. And then I'll seal our time together with just a brief reading. And you can allow this to plant a seed in the mind, body, and spirit. And just take this with you wherever you go from here. And it's called Sabbath time. Work when there is work to do, and rest when you are tired. One thing done in peace will most likely be better than 10 things done in panic. I am not a hero if I deny rest. I am only tired. Continue to care for yourself, please, as you care for others. And please take this out of this time and into your life. I appreciate you. And I'll see you next week.
Thank you, April.
Thank you.
Ready for bed.
I know. Me too. Have a beautiful...
I'll see everybody May 30 and again on June 6th. Thank you. April. See you.
Namaste.
See you next weekend. Bye. Appreciate you.
Good night, everybody.
Be safe.
Bye.
Good night.
Good night.
Good night.
Good night. 159.
I saw that.
Yes. Thank you. Thank you.
Good night.
Good night.
Good night. Thank you, everything.
Your cell phone. Good night.
Thank
Thank
you.
you, Carol.
Thank you.
You're welcome.
Hi, Des.
Okay. I'm ending meeting for all.
Okay.
Thank
Everybody.
Bye, everybody. Next Saturday.
Everyone. Thank you so much.
Thank you,
May.
everyone.
Thank you, May, for coordinating. Thank you so much.
He always has a great
You're
job.
welcome.
Bye.
Bye.
Have a good night.
MaryAnn, thank you.
Thank you. You were awesome. Thank you. Appreciate it. It worked out great.
Thank you, Maureen, if she's there still.
Night, everyone.
Night. I'm ready for bed. I'm so relaxed.
I know.
No dancing? There's no dancing right now?
No, maybe tomorrow.
We can dance virtually, MaryAnn.
I will certainly.
Yes.
You know me.
Okay.
I will certainly be there.
Thank you. Good
All
night,
right.
everyone.
Good night, everyone.
Good night.
Ending meeting for all.
Thank you.
Thank you.